Hi, my name is Danish Maslamdoost. I'm the medical director of a clinic in Lexington, Kentucky called Wellward Regenerative Medicine. It's a practice that was begun by my parents in the 1990s. They're both physicians. My father was an anesthesiologist and pain specialist. My mother originally was an anesthesiologist and then transitioned into psychiatry. So they had one of the first multidisciplinary clinics in the country, and I grew up there. So when I went off to school and med school and beyond, my interest in pain remained. When I finished my training, I came back to Kentucky to join them in the practice, and I was astonished by how problematic pain management was and opioid overuse and dependency was in Kentucky. I very quickly realized that in order for us to be able to make a dent in this, first I had to figure out a new paradigm or a new way of addressing pain, and second, I needed help. So I've developed this CME program to help educate my colleagues and the lay population, because what we know about pain and how to manage it has just been very skewed over the years. So what we'll talk about, and I will mention that if any physician would like to get continuing medical education credit for this, there will be an option to do so with instructions that I will add in a little bit later. So what I'm going to talk about is the epidemiology of opioids, the evolution of pain mismanagement, or how we got off the rails with this, and the CDC guidelines with their rationale, why they're built the way they are, and finally, the paradigm shift that we need to make across healthcare to go from palliating pain to actually healing it.
Here's a scary fact. In 2014, 47,000 Americans died from drug overdose. That's a new record. But if you peel back the numbers, many of these Americans are not dying from illegal drugs. The main killer is not cocaine, meth, or heroin. Instead, totally legal opiate painkillers were the biggest cause of overdoses. How did we get to this point?
So in the 1990s, doctors were under a lot of pressure from advocacy groups, the federal government, to treat pain as this really serious medical issue. And there was pretty good reason for that. There were about 100 million Americans suffering from chronic pain.
The undertreatment of pain is a major public health problem, whatever the cause. Some end up shuttling from doctor to doctor, desperate for relief.
Under this pressure, doctors turn to opiate painkillers, highly potent drugs that bind to receptors in the nervous system and reduce pain messaging to the brain. And one reason doctors turn to opiate painkillers is because drug companies like Purdue Pharma said that they were safer and less addictive than other painkillers on the market.
We now find that these medicines are much safer, much more powerful, much more versatile than we used to think, and we feel that they should be used much more liberally for people with all sorts of chronic pain.
Yeah, that wasn't true at all, that these drugs were safer than the other ones on the market. And in fact, Purdue Pharma ended up paying hundreds of millions of dollars in fines for its false claims later on.
The damage had been done, and by 2012, physicians wrote 259 million prescriptions for opiate painkillers, enough to give a bottle of pills to every adult in the country. Since opiate painkillers are so addictive, millions of patients got hooked on the drug. And as use proliferated, many patients overdosed. In 2014, nearly 19,000 drug overdoses were linked to opiate painkillers, about 40% of all drug overdoses recorded that year.
So yeah, here's where it gets really ugly. The doctors began pulling back these prescriptions, but what that actually ended up doing is that because these painkiller addicts were already using and addicted to opioids, they just went to another opioid, heroin. People who are addicted to painkillers are 40 times as likely to be addicted to heroin. Since 2000, heroin overdoses are up by 500%. More than 10,000 people died of heroin overdoses just in 2014.
The government is finally responding to this whole problem. The Obama administration, along with local, state, and private efforts, have significantly increased funding for prevention and treatment programs.
So the problem began in the 1980s when it was realized that a lot of palliative care patients and end-of-life patients were inadequately treated. The notion became that in order to get these people better care, we needed to develop some safety and comfort around prescribing opioids as one of the tools to managing pain. Somehow this got translated into non-cancer related pain, or regular bread and butter issues like musculoskeletal joint pains or headaches, myofascial pain, and the problem started evolving. So prior to the 1980s, there was very little opioid use across the country, but after that focus on pain developed, there was an astronomical rise in opioid use in the U.S. And I will say that this trend has continued to increase. This slide only goes to 2010. In spite of being only 5% of the global population, we end up consuming 80% of the world's opioids. And when you look at medications that you can go home with, or the medications typically used in chronic pain settings, we actually consume even more than that. For hydrocodone, we're consuming 99.7% of the global supply, and for oxycodone, it's 70 to 80%. The problem is so pervasive that we actually prescribe more hydrocodone than any other medication for any other condition. That includes hypertension, thyroid medications, antibiotics, or medications to address diabetes or cholesterol issues. And in spite of this dramatic escalation in opioid reliance, we do not have a population that is more comfortable. If anything, we're having increasing rates of Americans complaining about chronic pain issues across every demographic and age group. When you look at the problems evolving from opioids, ever since that introduction of the World Health Organization's opioid ladder, we see this dramatic escalation in drug overdoses. In fact, the number of people who are dying from opioid overdoses supersedes those from heroin and cocaine in their epidemic states. In 2000, we had approximately 10 overdoses per day. But by 2012, there was one every 30 minutes. And when you look at the trend, this slide only goes to 2006, which would be right here. We've seen continued escalation and growth of opioid. In particular, since attention has been focused on opioids as a problem, we've seen a transition from opioids to heroin and fentanyl, other types of opioids. Between 1999 and 2015, there were over 377,000 deaths from prescription drugs and heroin. Just to give some perspective, Lexington is approximately 300,000. So this is more people than have been more people have died from opioid overdoses than the entire population of Lexington, combined with Georgetown, Kentucky, combined with Frankfort, Kentucky. For years and years and years, car accidents were the number one cause of accidental deaths, but now we see drug overdoses have actually superseded that. We see the number of people dying from drug overdoses is even greater than the number of people who died at the peak of the HIV epidemic. When you look at a map showing the cross-section across the country of opioid deaths, if we look back to 2003, we see the epicenter being in Appalachia. There's a few other places across the country, but I'm going to do a time lapse over the next few years of how this problem continued to evolve and consumed essentially the entire country. There are very few places in the country you can find that do not have this opioid problem. If you look at the prevalence of overdose compared to how much opioids are prescribed, it's a very, very close correlation. Higher prescribing states have higher numbers of overdoses, and in particular in this Appalachian region, we have among the highest. When we look at Kentucky, we rank fifth highest for illicit opioid use, and depending on the statistic you look at, between the third and the fifth highest rate of opioid overdose. The population most at risk are men, Caucasians, indigent population, rural population, but in particular people with mental illness like depression. Even though men and Caucasians are still at the highest demographic risk pool, we see a very dramatic increase in women and all ethnicities. This is not a selective condition. So if we look at particularly the rural population in Kentucky, we see this higher prevalence of opioid overdoses in eastern Kentucky, where practice patterns have been heavily influenced by pharmaceutical companies. And I won't get into the details of that in this lecture, but it is fairly dramatic and concerning, the level of immunity that they were able to convey incorrect information to primary care practitioners. In eastern Kentucky, 50% of them have friends or family who actively abuse opioids. Among the Medicaid population, which is more prevalent in this region, they have double the rate of opioid prescribing and 6 times more likely to overdose. The financial toll in Kentucky has been pretty high. We've seen an increasing expenditure for opioid overdoses. And if you look at the populations from whom payments are coming from, the majority are coming out of the public payers. And I'm sorry, this should be 48%, not 58%. But the societal costs of opioids are not limited to just the expense of managing the complications. There's also a great degree of loss from loss of productivity and people leaving the workforce because of pain, much of which is poorly managed pain. And while we talk about overdoses as the big concern, it's really the canary in the cave. The CDC estimates that for every one overdose, 10 people are admitted for opioid abuse. 32 people have ER visits because of misuse of opioids. 130 people are physically dependent or actively abusing, and 800 people are using opioids without a prescription. Most of these medications are coming from friends or family. It's free medications. We always think of this problem as being a problem from drug dealers and people diverting their medication, but it's really a smaller fraction compared to the number of people that are just simply getting it from friends or family. For years, the tendency has been overprescribing. People will have a surgical procedure and go home with 90 or 120 pills of hydrocodone, where as they only end up using 1 or 2 of them, and then they have a full bottle sitting in their medicine cabinet ready for somebody's misuse. These medications are primarily being prescribed in emergency rooms and primary care clinics, fewer coming out of specialists. And in Kentucky, we see a trend of younger and younger people starting with opioids. 1 in 7 Kentuckians under the age of 30 have misused opioids in the year 2012. And this is particularly concerning because we're seeing opioids becoming number 2 most commonly used drug, second only to marijuana. But these numbers are increasing, and we're seeing more people exposed at a young age. And the reason this is very concerning is because, in spite of what any teenager will tell you, their brain does not fully develop until they're in their 20s. And when they're exposed to opioids, it actually affects the way the reward system in the midbrain develops and matures. And so the example I use for folks is if you went to an amusement park and the first thing you did was ride the fastest, scariest roller coaster, the Ferris wheel that you ride after that is not going to be as exciting. And so it diminishes the reward mechanisms out there because it's artificially inflating it and setting a standard that normal life goals will not compare to. This makes it very prone to being a gateway drug for future escalation in drug use. Children are affected in many different ways. It's not just the exposure to parents who are not being active parents because of a drug problem, but also accidental overdoses are pretty prevalent among kids. The mean age of an accidental overdose for a child is 2 years old because they don't quite know the significance of the medications they might inadvertently swallow. And the volume of legitimately prescribed opioids directly correlates with the number of children in the community having overdose. This has become an all too prevalent image in social media and on news and TV. This child, for instance, was...
The video is heartbreaking. A 2-year-old girl crying and pulling at her mother, lying unconscious on the floor of a Lawrence family dollar. This cell phone video obtained by Lawrence police shows the darkest side of drug addiction that officers have seen.
All too common, kids are being neglected because of drug problems. In Kentucky, I have many patients who are grandparents but raising their grandchildren because the parents are absentee. I couldn't find statistics for Kentucky, but in Tennessee, the neonatal abstinence syndrome, or kids born to mothers of opioid dependency, are pretty striking. Tennessee's done a lot of work in this arena. They've noted that nearly 40% of Medicaid enrollees, women in that age group, in the childbearing age group, were prescribed an opioid medication, meaning that women are already physically dependent on opioids prior to getting pregnant. So what's going to happen when they get pregnant? They're going to maintain that or continue that. It's very difficult to stop an opioid, let alone stop it while dealing with pregnancy. We see a higher number of people in Medicaid population affected by this. 42% of neonates in withdrawal had mothers that were prescribed an opioid, meaning that the mother was obtaining pain medications from a physician all the while that they were pregnant. Whether those physicians knew about this or not is unclear. The cost to Medicaid of newborns who are opioid dependent, on average, an average newborn costs around $4,200 for birth and any post-birth care. But a child who is born with opioid dependency costs on average $67,000. These kids continue to have problems throughout their lives. We see a 15-fold higher rate of Child Protective Service custody for children who were born with opioid use, neonatal abstinence syndrome. And there seems to be evidence that these kids will also have learning issues. When the children are born, they have a lot of health problems. They often have convulsions and tremors. Their physiologic system is dysregulated. Their sleeping patterns, feeding patterns, bowel habits, their birth weight are all adversely affected by opioids. And when you look at the long-term sequelae, there's evidence that shows that kids who have neonatal opioid withdrawal syndrome will have hyperactivity, attention deficit problems, impulse controls, and higher rates of addiction later in life. This goes back to the developing brain, and when you expose the developing brain to such a potent neurotransmitter as an opioid, the systems in your brain that do develop endogenous sources of opioids are underdeveloped and lead to problems. What's even more concerning is that opioids are known to cause DNA methylation. DNA methylation is an epigenetic effect where it alters the expression of genes, not just in the active patient, but also in the progenitor cells of that person. So the ova, the sperm, will show changes in their DNA expression because of the exposure of opioids. If we look at the adult population, there's a great deal of evidence that shows when you expose an injury to opioids, that problem is much more likely to become a chronic disability and increase the cost of care. If you look at the disability rates from the 2000 census, Kentucky and West Virginia vie for number 1 and 2, and that correlates with the propensity of opioid dependency and abuse. Not really alluding to a causality, but there is a correlation. In Louisiana, they did a study in the workman's comp population looking at a 10-year span where workers who were injured in that time frame were followed up, and in the early part of this decade, patients who were prescribed an opioid were only prescribed something like 10 milligrams a day on average, and only 43% of them were prescribed an opioid. But by the latter part of that decade, 80% of injured workers were prescribed opioids, and at much, much higher doses of medications, 143 milligram average morphine equivalent daily dose. MEDD is just a way of kind of creating a metric for opioid potency, since every opioid has a different milligram potency. They found that the duration of claims were longer for patients who were prescribed opioids. Now, one could argue that severity of injury could also affect this. However, in other studies, it was demonstrated that severity of injury has less to do with long-term outcomes of disability than does opioid exposure. And longer-acting opioids have higher rates of disability and the onset of opioids has an impact on the probability of disability. People who were prescribed an opioid within 15 days of injury on average had higher number of days on disability, 3-fold higher rates of surgery, and 6-fold higher rates of continuing to be on an opioid later in life. The potency has an impact. Stronger opioids have higher rates of disability than weaker opioids, and they do increase the cost of care. The analogy I use is, let's say somebody comes in with a broken foot. Well, the typical course of action would be to cast it. But instead of taking this approach, let's assume that everybody who comes in with pain in their ankle is a sprained ankle. And what do we do for a sprained ankle? We give it conservative care. So instead of casting that foot, we don't do any kind of workup. We just make the assumption, and we give them some pain pills and send them out the door. Well, it's common sense to assume that if you don't cast the leg, if you don't fix the bone, and all you do is mitigate some of the symptoms, that eventually that person is going to end up with a disabling condition. But that's essentially what we've been doing with a wide number of pain complaints. Somebody presents to their physician with a condition or a symptom. The typical course is to figure out what is the cause of that. But with pain, we've essentially taken that cause-effect relationship and ignored it. All we do is we look at the symptom and we drop a whole bunch of opioids on it to mitigate that symptom. But then we don't really go into great detail in figuring out what is the cause of that. And I'll talk a little bit more detail about that later, because I'm sure some folks would disagree because they're getting MRIs and they're sending patients to surgeons. But even that has some deficits to it. So, in effect, if you ignore the cause and you only address the effect, or essentially you ignore the disease and you only address the symptom, the disease is going to continue to grow, and it's going to make it more difficult to treat down the road. The other problem that's created with opioids is a rebound effect. Well, when you take an opioid, or if you prescribe an opioid to somebody, there is an analgesic effect where their pain intensity is going to be decreased for a period of time as a result of the analgesic effect of that medication. However, the body's like a rubber band, and if you pull it in one direction, it's going to recoil in the other direction. And that rebound effect can outlast the duration of effect of that medication. So when patients feel that rebound effect, they become hypersensitive to pain, and whatever the originating pain issue was, the impression is that it has gotten worse now, and so it's time for a redosing. And if that's overlapped with a pain generator that's acute, that we know it has a time course, it's going to go away, then that overlap can be negligible. That rebound effect may be negligible or imperceived. But the problem comes when you're dealing with a chronic pain issue that's not going away. Well, in that case, you essentially end up in this cycle where you're trying to treat the rebound pain with more medication, and people fall into this perspective that they need the medication because the pain is constantly coming back, where in fact they're actually experiencing a rebound effect from the medication itself. So typically, a patient will get started on an opioid, they'll be titrated up, and then they'll reach this maintenance phase where medication will just be maintained. And that's never really challenged, because typically what ought to happen is there ought to be some challenges to this homeostasis. The pain medication in and of itself will form people will form a tolerance to that medication and won't really have a great deal of benefit from it until it's challenged and see how much of an impact it's having. You could make the argument, though, that chronic maintenance could be done at a massive escalated level or any level in between, but the outcome or effect can be very similar, because when a patient is walking on a plane, they have no idea if that plane is at sea level or if it's 10,000 feet in the air. What I say is that the problem with opioids is when you introduce it to pain, the line between the actual pain generator and their dependency and hyperalgesic effect becomes very blurry. So it's very hard to differentiate if somebody is dealing with rebound effect from medications, and that's what's causing their pain to be intolerable, or if it's physiologically derived. In our current model, a patient presents with pain, they're immediately pumped into this pipeline with opioid exposure. And of the patients who are exposed to opioids, some of them are going to become addicted, and of those people who become addicted, some of whom are going to be are going to have an overdose. We don't differentiate between these two patient populations, and really we ought to, because the patient who's presenting with pain, particularly the opioid naive patient, is somebody who could be very effectively helped with a pain specialist. But if we treat every single patient with pain the same and we introduce those opioids, then we're not really differentiating between the people who are opioid tolerant pain patients from the patients who have a behavioral level addiction and pain on top of that. And that's important because our patient selection and how we treat these patients and how we address this issue long term becomes very relevant if we don't differentiate between what an addictionologist does and what a pain specialist ought to be able to do. You can think of this as differential population being the opioid naive population, for whom we need to protect and prevent pain, acute pain issues from becoming chronic pain issues, or essentially protect them from developing chronic pain from an acute injury. Then we have the opioid-dependent patient who does have pain, for whom, if we only prescribe pain medications, once they reach a homeostasis with their medication, essentially we're not treating their pain anymore. We're just maintaining a level of medication and ignoring the pain. So in this population, we need to address the pain, but we also need to get them back to a normal physiologic response to pain by weaning their medications to a point where it's not a daily dependency. It may be there available a few times a month for their worst exacerbations, but not a daily routine. And then finally, we need to look at the patients who are opioid addicted and call a spade, not pretend like this is a chronic pain issue that masquerades their addiction, but really identify the behavioral components that reflect an addiction and treat the addiction. If they have pain on top of the addiction, that needs to be addressed as well. But the addiction will supersede any kind of pain treatment because it's going to cloud what impact treatment has. And the reason for that is that the pain response in the brain is very intertwined with the addiction centers of the brain. So just to follow the train of a pain signal, if it starts in the body, the first place it is perceived is in the spinal dorsal horn. That's part of the spinal cord that relays pain signals to the brain. And the first place that stops at is the thalamus. The thalamus is like the relay center of the brain. It decides what signals go where. And so whenever a pain signal comes in, the thalamus shoots it out to the somatosensory cortex, which is the area of the brain that determines what location pain is coming from, as well as the frontal neocortex, which is the conscious thought of pain. This is the center of the brain that has thought and understanding and interprets the perception of pain into something that's uncomfortable and unpleasant and undesirable. From there, signals will be shot over to the periaqueductal gray matter. That's one of the innermost parts of the cerebral cortex. That's where a lot of other autonomic relays and emotional state relays will also innervate, and they can paint how much endorphins are being produced. So the periaqueductal gray matter is where the brain produces endorphins, and those endorphins will affect the brainstem by turning on or off nerves that produce serotonin and the rostroventral medial medulla, or norepinephrine in the dorsolateral pontine tegmentum. Now, it's not critical to know what exactly is happening in this area. It's just important to understand that there are neurotransmitters that affect how the spinal cord will react to a pain signal coming in, whether it will suppress that pain signal or if it will amplify that pain signal. And this is a very key part to figuring out chronic pain issues, is what's happening at the spinal cord and whether that signal is being amplified or turned down. Now, how we correlate back to addiction is that the nucleus accumbens in the midbrain also produces dopamine, and we see that in patients who have an addiction problem, there's an upregulation of a protein called delta phos-B, and the increase in dopamine will also affect the dorsolateral pontine tegmentum of the pons, because dopamine does convert into norepinephrine, and this dysregularity is one of the main reasons that depression, pain, opioids, and addiction are all interrelated. We see the trends in addiction reflect this, that as prescription opioids have become more prevalent, the addiction trends have also increased. Up until the 80s and 90s, heroin was more prevalent in the addiction population than, for instance, opioids. But since the 1990s and the transition to prescription drug use, we see this reversal where opioids have become more heavily abused than even heroin. Now that attention is being placed on this issue, we see that trend reversing. Some would argue that's because we have exposed more people to opioids, and that heroin is a cheaper source of that same opioid impact. And this seems to be affecting all demographics. Previously, they were primarily younger folks were affected by addiction. Now we're seeing this raising age, indicating that addiction is no longer experimentation of youth, but rather something that is more and more prevalent among older people. And we know through the CDC that heroin addiction is on the rise. By leagues, it's on the rise, and this is particularly alarming in the female population, where we see 100% or doubling of heroin use versus in men, 50% increase. And that this is a problem that affects every income demographic, whether it's the impoverished. We're seeing 60% increases, the middle class 77%, and upper classes being 60% growth in heroin use. A lot of this is attributable to the opioid epidemic. We see that patients who have been addicted to opioids are 40 times more likely to be addicted to heroin, a statistic that's becoming more recognized. Source for some of this information is Dreamland, which is a book by Sam Quinones. He chronicles the evolution of black tar heroin in the U.S. It's more focused on the heroin issue and how opioids have fed into black tar heroin's growth, because it is. And like the video at the beginning of this presentation stated, there is more attention to this as a result of the efforts from multiple different public and private organizations. There's more focus on addiction with focus on reducing some of the contributors to this opioid epidemic. For instance, pain is no longer deemed as the fifth vital sign. Vital signs are objective measures of health, whereas pain is a subjective impression, and constantly reminding patients of that is not helpful. Previously, patient surveys on pain satisfaction were one of the determining factors to reimbursement, and this has caused providers to be more liberal and aggressive with opioids, in spite of the fact that we're not necessarily treating pain better, we're just prescribing more opioids, and that is not a reflection of better pain management. It's just a knee-jerk reaction to try to quell your reimbursements for being cut. Legislative changes across the country that are seen as impositions, but are really just wake-up calls. In 2011 or 12, Kentucky passed House Bill 1, which in some perspectives re-legitimized the pain specialty, because it regulated pain clinics, and we saw a great reduction in the number of clinics. I want to say, and don't quote me on this, that before 2011 there was something like 40 or 80 clinics, and that number was cut down into the teens after House Bill 1 went out. Kentucky also passed a recent legislation, House Bill 333, which limits the first prescription provided to somebody, meaning somebody who is opioid naive. If they have an injury or they have an issue for which the physician would like to prescribe opioids, it limits it to 3 days. Now, there are a lot of of loopholes to this, where if a physician deems it necessary, it is able to be circumvented and more medications prescribed, but it at least creates a speed limit where justification has to be shown for prescribing more. And we'll talk about why that 3-day limit is relevant and it is actually beneficial. There are 10 other states that had prescribed similar legislation, and I believe since this presentation was formed, there have been more states to pass legislation limiting opioid prescribing to less than 7 days, again with really good reasons, which we will cover in in the second lecture, or the third lecture that I'm going to give on this in this series. So this concludes the first presentation. If you'd like to continue on with the subsequent presentations to obtain the full CME credit, one of the requirements of House Bill 1 is for all Kentucky physicians to have a certain number of opioid-related CMEs, and if you fulfill the series, all of that will be completed. Thank you very much for your attention. Hi, my